Okay, thanks. I think we can start. I'm Dr. Indira Govender. I'm based in KwaZulu-Natal, and I'm a member of the Executive Committee of RuDASA. And I'm really happy to introduce Dr. Sybrich Tiemersma, who will be presenting the webinar this evening. Thanks to all of you who've joined. Um, Sybrich, if you want, yeah, your camera is on, great. So Dr. Sybrich Tiemersma is a pediatrician who's trained in the Netherlands. She's practicing in South Africa since 2019 and works at GJG Mpanza Regional Hospital in KwaDukuza, that's in KZN. She's currently undertaking her master's in public health with severe acute malnutrition as a topic of a research. She's interested in research and quality improvement projects and is also the national coordinator of the Child PIP program and has a heart for rural health, which is why she's here today. So thanks very much, Sybrich, for joining us. I will hand it over to you. Yeah, go for it. Oh, sorry, one more thing. If you have any questions, please feel free to write it in the chat if you can, and we can discuss it at the end. But if you don't mind, please keeping your microphones on mute. Thank you.
All right. Thank you, Indira, for that kind introduction. And thank you for the opportunity to present here on severe acute malnutrition. It's a privilege for me as a foreign trained doctor to present to the rural doctors. So thank you for that. I just want to confirm that you can hear me and that you can see my screen.
Yes, I can hear and see. If anyone is having any difficulty, please let us know. Otherwise, yeah, we'll take it that everyone is connected. Thanks.
All right. Thank you. It's actually it's started to rain now here. So also, and I'm on a booster for the internet. So I'm just gonna put off my camera for now for bandwidth. Um, so thank you everybody for joining this meeting on severe acute malnutrition. I am a pediatrician and I assume that the problem that we are seeing in our local provincial hospital regional hospital, apologies, in KwaZulu-Natal is a problem that is seen everywhere in South Africa. And I know some areas are worse off than others. I know Limpopo is also having a high rates of SAM, but we are also still there. So let me just see if this one wants to move forward. This photo is literally made 2 hours ago as I left our acute admissions area. And this baby is 7 months old, weighing only 3.5 kilos. And yeah, it just breaks my heart when I see this because where was this child all the time and why is he not growing? And unfortunately, this looks like this is a primary SAM, so not a secondary SAM. So I'm going to take you along in this presentation. What I'm going to do is I want to do a little bit of background information on what is actually malnutrition, how are we looking at it, what are the determinants, before we actually get to the practical side and the interventions and the new guidelines that are out or that are just about to be published. So basically, the concept of malnutrition is not just the undernutrition, it's also overnutrition and the micronutrient-related malnutrition. But we are mostly focusing in South Africa still on the undernutrition, although we all know that the overnutrition is actually also starting to become a bigger problem here in South Africa. So SAM in South Africa has got very different forms, and I just want to pose a question to you guys. How many children in South Africa do you think are stunted at the moment? You don't have to answer it. You can post it in the chat if you want to, if you know the answer. The answer will come up later in this webinar. And so how many South African children are stunted? And my second question, which I will answer just now, is how many South African children between 1 and 2 years have eaten any protein in the last 24 hours? And this is not really a question that we often sort of think about, but we know that protein is the main problem in the diet that is missing if they have very starch-based food. So it's interesting to know, what is my kid that I'm seeing in front of me, what have they actually eaten? And protein is often missing. The answer is that in the poorest groups in South Africa, they've done studies. They say it's 35% that have eaten any protein in the last 24 hours. So you can imagine what that is in a week. Maybe they eat very rarely, maybe some chicken or some eggs. But yeah, it won't be as nice variety as we see here on the picture. But in the richest group of the South African children, it's 90%. So you see, if you look at that, the South African country is the most unequal, even in the amount of protein that our kids are eating. So if you look at it from a worldwide perspective, this is from the WHO and UNICEF, we know that stunting is actually our biggest problem, and they estimate that nearly 150 million children all over the world are stunted. Wasting and overweight are sort of competing, where wasting is also a huge problem with 45 million children and overweight 37 million on the rise. Overall, the trends are showing that the number of stunting is actually decreasing quite beautifully from about 1 in 3 children, as you see here on the left, that's a percentage, to about 1 in 5 children over the past sort of 20 years. However, and if you look at the overweight and the wasting, it's actually sort of similar. It's slowly on the rise. But if you look at these numbers, you can see that if you look here on the right top, the decrease in the number of children that are stunted is only due to the impact that Asia is doing. They have been doing major strides in improving the child health and improving the malnutrition rates. And you see that in Africa, the stunting rates are just actually flat and not really changing at all. So malnutrition in South Africa, the answer is here. The stunting is between 27 and 29%. And apologies, I can't see the chat, so I'm just going to look at that later. But we know that overweight is also slowly on the rise. At above 5 years, nearly 1 in 5 of our kids is overweight. So it nearly goes hand in hand. And you often see stunting with overweight at the same time, interestingly enough. So I really want to recommend this report if you want to know more about food poverty as well. What does it actually mean? And what they are talking about, what is food poverty, is basically here at the top. You can see that you have to talk about food groups. So this is now, for example, starch and fats and proteins, and you got all these different food groups. And if you eat only 0 to 2 food groups a day, you are considered to be in severe child food poverty. If you eat 3 or more, it's moderate child food poverty. And if it's 5 or more, then you're actually fine. So you see South Africa here, 23% is in severe food poverty and another 37% is in moderate. So this is actually quite significant. And if you look at it per country, we are somewhere in the middle, where countries like Albania, Burundi is even doing better than us. Kenya is doing better, Rwanda, Thailand, Brazil doing much better. So yeah, we're not doing really great here, seeing how much wealth there is in this country. Another thing from this report is the relationship between child food poverty and household income poverty. And I like this, what they say. They say severe child food poverty is the result of systems that are failing, not families that are failing. And they say, although parents and families have a responsibility to feed and care for their young children, the forces that lead to severe child food poverty are beyond their full control. And you see this vicious cycle where you have poor growth and development, lower school achievement, household income poverty, and this cycle just keeps on going. And we know this. This is just something that we know and that we see. So let's dive a little bit deeper into child hunger in South Africa, because I think there's a little bit more to say about it. If you look at this report, you can see from 2002 and 2018, there is some good news, apologies, that the children living in households with reported child hunger is decreasing on a very amazing trend. So in 2002, there was about 1 in 3 children were living in a household with child hunger, and it's only 1 in 10 on the South African scale in 2018. And you see, even in the Eastern Cape, there's been a dramatic improvement. But also other provinces have done really well. So this is one way of looking at it. And this is from a general household survey. But on the other hand, other reports from Stats SA also report that 1 in 4 households still consider their access to food as inadequate or severely inadequate. And that also differs a lot per province, as you can see. Something that is really interesting to look at what I follow every now and then is the Household Affordability Index. This is published every month. And basically what this NGO does is that they send mothers to do their monthly shopping. And they have to buy all these food items that you see on the right. And they basically see what is the pricing of that for a month. So if you buy, for example, let's choose the onions, 10 kg here in the middle. In April 25, this cost about 101 Rand and 30 cents. And now it cost them a year later, 121 Rand and 38 cents. So you see overall, there's some things that are cheaper and some things that are more expensive. And this averages out throughout the country as you see the cities that they're doing it on the left. So compared to last year, actually, our food basket is a little bit cheaper. But their conclusion is always as follows here at the bottom. In April 26, the child support grant is 32% below the food poverty line and 40% below the average cost to secure a basic nutritious diet for a child. So they're just saying with a child support grant, if that's your only income, you're not able to buy even these normal foods. So we're not even talking about toothpaste, about clothing, and nothing else. This is just looking at what this food cost that you saw on the other slide. So I'm not going to go too much into detail, but it's very interesting. In 2023, there was a parliamentary question about the number of malnutrition, and this is what was presented there. That they estimate that in South Africa, 30 children die from malnutrition-related causes. So that's a classroom a day, guys, in South Africa. So that's about 10,000 per year. And about 1,000 is directly caused by SAM, and another 9,000, so this is only under fives, but SAM is an underlying factor in the death. And there is another 10,000 children per year that die, and they also were underweight for age. So this led to a press statement also related when there was a lot of post-COVID attention to child food poverty and the problems. So the SAPA and the Children's Institute, they published this press statement saying that in 2024, 4 out of 10 children live below the food poverty line. And they say the incidence of SAM is increasing by 23%. I have got a few numbers from our own hospital. And it's always a bit tricky to present, but we have actually quite a high case fatality rate for SAM in our hospital. You can see our number of SAM separations and SAM deaths here on the right. It's quite static. And you can see this line here for our case fatality rate, and it's actually on the rise. There are multiple explanations for this. One is that, for example, we also counting lots of secondary SAMs, meaning the children with CP and cardiacs, and we got a lot of those in our institution. And sometimes there's a lot of late presentation, but unfortunately, there's also still a lot of primary SAMs that are really, really sick. And TB is a big problem for us. So yeah, I would like to hear your stories. What is your case fatality rate and what are your issues? And it's really nice to do a sort of investigation. What is our problem? So we'll get to that just now. So a classical road to health card that you can see there with the growth nicely plotted and the baby only referred at the very end. Shame. This must also probably be something that people recognize all over. Okay, another question. Are you guys ready? Formula-fed babies have a 15 higher chance of dying from pneumonia than breastfed babies. Is this true or false? Sorry, I'm still recovering also from the flu, so my voice is also a bit on and off. Before answering this question, I want to take you on the background of what is that framework of malnutrition that was designed by UNICEF in 1991. And it talks about sort of what are your basic causes, so in society, your underlying causes, your immediate causes, and then the manifestation is malnutrition. So it's a multi-layered problem. Currently, it looks like this, published already also a few years ago, but basically what they also say, there's basic causes, so social, economic, lack of capital, underlying causes. So these are, household related, employment or non-employment. And then there is system causes, so like household food insecurity, inadequate care, and then immediate causes. So then you get sick or you've got an inadequate dietary intake, and then you speak of undernutrition. You got short-term consequences and long-term consequences, and it's also related to intellectual disability or less ability than you're not reaching your full potential, leading to less economic productivity and poorer reproductive health as well. So the determinants of malnutrition in South Africa are multifactorial. And these are all different for each of the areas where you work, but I'm sure you all recognize your problems in your area. And it seems like impossible to address all of it. So where do you start? And who do you involve and what do you do? And I think these things are always small wins, small little steps, and lots and lots of engagement with your communities. What I want to focus on as well is that underlying with all these other determinants, the inflammation that is in that child is ongoing, and it's a driving force of worsening. Because once you are in a state where you've got malnutrition, you often have a lot of enteropathy. Then you've got altered microbiota, increased bacterial translocation, and the children just get sick. So they easily get a sepsis. The inflammation is caused by the malnutrition. So by being malnourished, your immune response and your inflammatory response just goes up. Often the children are also fed porridge very early, also damaging the gut from the outside. Then you also have that the other organs are breaking down, like your skin break down, you're lethargic, you don't want to eat. And your immune system is also less potential, less active, or less potent than it actually should be. Apologies. And we know that malnutrition on the long term is related with non-communicable diseases like diabetes and stroke, and ongoing malnutrition and stunting, and then overweight at a later age. Here's the answer to our question, guys. Pneumonia mortality for not breastfeeding children, 15 times higher compared to fully breastfed children. And the all-cause mortality is 14 times higher. Now, obviously, I'm a pediatrician, so I'm very pro breastfeeding. So I take the numbers that are most dramatic. But now you can say it to all your patients. The pediatrician has said breastfeeding is best. Okay. If you cannot feed 100 people, just feed one. Okay, I'm going to skip this one. This is basically sort of the same as we were talking about before. The only thing what is interesting from this article publication from the Lancet is that they actually looked at the bigger blocks on the outside, where they say, what are your approaches and your programs that you can do? So there's a lot of evidence that went into what is actually things that we can do that are evidence-based for malnutrition. And I want to take you through this little table here, because a lot of the stuff we already do in South Africa. So we're already doing a great job, but these are like strong evidence for implementation. So if you want to do something, this is where you're going to start. I think it's nice in every institution, you're also able to start with these things because look, it's not that complicated actually when you look at it. It's micronutrient supplementation in pregnancy, which I think we're doing. We're doing KMC for our prem and low birth weight babies. Are we doing delayed cord clamping, guys? That is, I think, one of the most important things, not just for prems, but also for term babies. Lots of stem cells and iron capacity going to the baby. Breastfeeding promotion, start early, and make sure that your teenagers that are pregnant already have an ID so that after birth, they can immediately ask for the birth certificate. It's not that complicated, but somehow it is. Vitamin A supplementation, zinc supplementation for diarrhea, This one is interesting. Small quantity lipid-based nutrient supplements for growth. We are not doing it at the moment. I don't think it's financially feasible for us to do it, but we are doing the ready-to-use food. And is it available in your clinics? And is it available in your institutions? We need to get that ready. Birth spacing, very important. Malaria, not in our, but maybe in Limpopo areas and the other areas a little bit more important. And food fortification is something that they do at large scale. And then you've got the other sort of moderate and weak evidence for what you can do as interventions. So another way of looking at malnutrition and tackling it from your institution, from your community side, is actually seeing what is, they call it a bottleneck analysis. And this was done at a larger scale for the country, but you can also do it at your local level and see what are now the problems, why are we seeing this malnutrition so much? You can look on the demand side, you can see, okay, there's less awareness, lots of use of herbal medicine was said. You can look at the supply side and the products are out of stock, HR shortage, inadequate supervision, technical support, lack of early identification. That's a huge problem with us. Quality of care, so the integration of child health. You only come for your immunizations, but there's no time to weigh. And also the environment was said, a cooperation between the other departments. Okay, so recently there's also been some publication of new guidelines. With the one on the right is the KZN guideline that is just recently published a few weeks ago. And there is a new national guideline on the way that you can see on the left. It has 2025 on it, but it's still not yet published. So we are eagerly awaiting the final publication of this one. It's a very nice, comprehensive, thick book, thick guideline that is going to be really helpful for all of us. So although it's still not fully published, I do want to take you along a little bit. The basis of these guidelines is still that when you see a SAM, you need to start with saying, okay, this is a now SAM. And the first thing, what do we say? We say, is there with or without edema? Okay, so that's your first step. So how you write it in your file, you present it, how you look at the baby, with or without edema. And then the next step is there any medical complications or emergencies? And the other step is that you're going to say what is the cause of the malnutrition. So there's already in how you assess the child with malnutrition, there's a lot of layers in that, and it already speaks a lot about your prognosis as well. We will get to that just now. So what are the medical complications / emergencies? So we know that if there is a complication, your mortality rates are much higher, and these complications listed here are we all know these complications, and these are actually for the under 6 months, but they're not that different for the over 6 months. And some of them are actually emergencies. And how did they come up with the difference between it? So some of the complications are emergencies, and that has to do with older studies that have actually said, okay, if you've got A, B, and C, then you are in a very high risk, moderate risk, or low risk. And all these risk categories come with their own mortality rates. So they say if you're in a high risk group, your mortality risk is about 1 in 3, moderate risk 1 in 2, and if it's low risk, it's much lower. And they've actually listed here what are the classical signs. Now, this is based on one study, on 2 studies, so it's not that evidence-based, and you won't see it in the guidelines so much, but we do teach this to our students as well, because if it's actually quite how do you say that? It's very easy to say, okay, I've got a depressed level of consciousness, this is an emergency and we need to treat it now. So this is just speaking to the fact, how quickly do we need to treat this baby? Okay, so I've highlighted actually 3 items because the guidelines are so massive. So I've just highlighted 3 items that I think are quite interesting for us today. We're going to talk about SAM, which are aged 6 weeks to 6 months. We're going to talk about fluid resuscitation in SAM in children with gastroenteritis. And we're going to talk a little bit about the last step in our WHO 10 steps, the rehab program, and what can we do. Okay, so one of the most important new updates is that from now on, we can diagnose SAM between the age of 6 weeks and the 6 months. And you can see here that the MUIC has to be less than 11 centimeters. And I actually want to encourage everybody to start doing that if we were not already doing that. So you can just say, this is a SAM, and the baby is 8 weeks old, based on a MUIC of 9 centimeters. Now you might be worried, now I'm going to diagnose the whole world with SAM. Well, maybe we actually should, because a 9-week-old baby that was born term with a nice birth weight of 3 kilos should not have a MUIC of 9.5 centimeters at that age. So it actually forces us to be doing much more earlier recognition. If you look at the light green circle here, you can see that they say even on a single measure, we can say this child is a SAM for the weight for length less than -3 and even weight for age less than -2, nutritional edema, and with a MUIC less than 11. But there's also these other groups that you think are at risk. So for a low birth weight baby or a small for gestational age baby, a prim, it's not that easy to say. So you always have to work with the corrected gestational age because the child still has a lot of catch-up growth to do. And you can also treat these groups differently. And I'll show you just a slide just now. And then obviously there's also this orange box where we know the children have maybe an HIE or has got a syndrome. So there's congenital abnormalities. Yeah, so there's lots of other considerations, but they still need extra attention when it comes down to nutrition. So those exprims and low birth weights are always a bit tricky because a lot of our children are low birth weights. So the new guideline encourages to not just look at those single measurements only, but actually to look at the weight gain. So if you are not growing, for example, you are now 8 weeks old, you're less than your birth weight, or you've grown less than 5 grams per kg per day, we can classify you as a SAM. I think in practicality, you just have to learn how to work with it. If you're not sure, discuss with your referral hospital. And rather, if you were already worried about the baby's growth, instead of contemplating is this a MAM and a SAM in this very precious age group with teenage mothers, lots of social issues, you'd rather just be safe and sorry. There's lots of things to sort out for this age groups. It's contraception, it's newly HIV diagnosis. It's so manifold, and I know the guidelines are different everywhere, that some of them need to be admitted. In KZN, all the children with SAM are admitted, in other provinces not. We don't have dietitians at our clinics, we only have nutritional advisors. So even the new KZN guideline advises to admit all the children with SAM, even if they pass the appetite test. But in other provinces, they made different decisions, and I think that's absolutely fine. If you pass the appetite test, you can keep these children at the clinic as long as you can see them for follow-up and you know that they're eating and gaining some weight. Okay, this is a very tricky one. What about fluid resuscitation in SAM? We have struggled with this a lot in our institution, and I don't know about other places. The situation, what we're talking about is a child who plots as a SAM, looks like a SAM, is shocked or not shocked, but we know he's got dehydration with gastroenteritis. What do we do? Looking at the guideline from 2013 from WHO, they have got a bit of a different guideline. Maybe you guys are familiar with this or maybe not, but they advised from a very, very long time ago to start with a bolus of 15 mils per kg over an hour. And that bolus could be given with 5% dextrose, with half saline or half DD, even with 5% dextrose. Remember, there's potassium in half DD. We don't really like that. Or MRL and 5% dextrose. And then if he doesn't improve, to give a blood transfusion over 3 hours of 10 mils per kg. And this guideline does not mention inotropes at all. So South Africa has not really followed this guideline. But just for the international literature, this is still, even now, the formal guideline. If you look at small studies that have been done before, they're comparing fluid type and amounts, but they've got very confusing results. And then this massive trial came out, the FEAST trial. I'm not sure if you are familiar with it. It stands for Fluid Expansion and Supportive Therapy. And it's one of the most discussed trials because it investigated children with shock and fever, but it did not look at children with SAM or acute GE. So that is actually our group that we are looking at. They gave 20 to 40 mils per kg over 1 to 2 hours as boluses, and they found a much higher mortality in the children that were given albumin as a fluid bolus or normal saline compared to controls. And even the 4-week mortality was much higher in the children that received fluid boluses. So based on this trial, we've become actually very much more careful with giving fluid boluses. And instead of recommending 20 mils per kg, we now say all children must only get 10 mils per kg, and no longer as a rapid push, but only a slow over 15 minutes or over half an hour as boluses. Then we had a next study in 2017 called the EFRIM study, standing for Appropriate Fluid Resuscitation in Malnutrition. And in 2 hospitals in Kenya and Uganda, they looked at children with hypovolemic shock and diarrhea with severe dehydration and SAM. So this is our group that we are interested in. And they saw a high mortality actually in both groups. But when they scanned the babies with an echo and did cardiac lab, they found actually no problem with giving boluses in this group. They didn't find an effect of compromised cardiac function, and they also didn't think fluid overload was common in this group. Another study is the GastroSam trial, which was actually published last year, and that stands for Rehydration for Severe Acute Malnutrition in Gastroenteritis. Also, again, this is our group that we are interested in. And they included 272 children in Uganda, Kenya, Niger, and Nigeria. And they compared oral rehydration with boluses for shock, which is our current recommendation, with intravenous rehydration with boluses for shock as a rapid infusion over 3 or 6 hours versus slow intravenous rehydration without boluses for shock. So remember, these children are in shock, but they're not giving a fluid bolus in this last group. And you know what? They found no difference in mortality, no difference in serious adverse effects, and no evidence of fluid overload, heart failure, or pulmonary edema. So where are we now after all of this? So when we first said, okay, we're not going to do any boluses, we're really worried about this malnutrition group, we are going to go slow, we're going to do not so much. We're now saying maybe there is a little bit more space to give IV fluids again. But I don't want to recommend this to you guys because you can see it's still an ongoing field of research. So what do the ETAD guidelines say at the moment? In SAM patients, you can give MRL or normal saline as a bolus, 10 mils per kg, but run it over 30 minutes. And if you're not sure if your baby is malnourished or not, rather just go a little bit slower. After correcting the shock, you can start your F75 and your oral rehydration at 20 mils per kg per hour for 4 hours. And I think this is still an excellent advice. Routinely, we also don't give IV fluids, but now and then, if the child is really having a lot of losses, and we see that actually quite now, every now and then we see it, we just give them a little bit of half TD fluid, sometimes even with potassium in it, just to keep up with the losses, but we do it usually at 2.5 mils per kg per hour. So there's only 2 reasons not to feed a SAM immediately, and I just want to put the emphasis on it again. A SAM needs F75 or any food, or preferably F75, even at the clinic. So if a clinic refers to you, they must just put food in. I know they don't have always, but they must try. The only 2 reasons not to give is while you are correcting the shock or if there's an acute abdomen. Okay, also don't forget, obviously, check your glucose, give antibiotics, remain normal temperature, and check your potassium. So that's all the first, how many steps of the WHO 10 steps? It's about the first 5 steps. And they actually preferably want this all to be done within an hour. I know it's really challenging, but the F75, you must give it within 30 minutes. You can actually do that on arrival if the baby's not in shock. Antibiotics within an hour. So yeah, it should actually just be possible, hey? Okay, let's talk about preparing for discharge. And I'm going to take this topic a little bit more broader because there is, some things that you can think about. What can I do in my institution? And over the years, we've implemented quite a few things in our hospital. And I just want to use it as an example of what you can do for these kids. So we have got a very nice established multidisciplinary team. And every Tuesday morning, we do bedside NDT rounds for all of our children that have malnutrition. And all of us give input, including the caregivers. And yeah, we actually make already, discuss a discharge plan for them. Our MDT is also part of in-service meetings with the caregivers where they sit with the whole group and explain about the grants, or it can be actually anything. And also our dietitians are doing that. And beyond that, every 2 months, we have a local IMA meeting where we meet and discuss cases and discuss our audits. Stimulation and play. We've got a separate ward, which we named Inkanyezi, just to make it a star ward. We've got a toy project that we're running where even our nurses and our doctors and the OTs and the speech, everybody gets a turn to make toys with the kids and just to play and do something else. We have books that are donated to us and teddy bears that we're giving to them. In our district, we link to our clinics and they go and visit the homes with the outreach teams and community healthcare workers, and they also give feedback to us. And sometimes we just get horrible photos of the living conditions of these people, or we figure out that this is actually not the caregiver at all. It's just the child was placed with someone else. And there's also some district meetings that we attend. We do a lot of family meetings. We actually put a lot of effort in it to meet the family and to see what is the problem. Often the mothers are teenagers. They are, just unwilling, or they've got difficulties in taking care of the baby. We help a lot with disclosure of HIV status. I think that's a big problem for us, that the moms have not told their status to their family. So we kind of, don't want to use the word force, but we kind of facilitate this disclosure to happen because the child often still needs the nevirapine and the AZT, or maybe even the ARVs themselves, or we really want the family to know what is happening. We assist with grants a lot. And I think, you can say, is this not really necessary or not? In our institution, it works really well. We've got an amazing contact at the Department of Home Affairs. Our social worker takes the moms there. It's a quick in and out, and they really want to sort the IDs for the mom. I think we really need to make sure that during pregnancy in our antenatal clinics, make sure that they've got an ID so that you don't have this problem after birth, that you don't have a birth certificate. We take care of our mothers. A lot of our mothers, we check them for TB. We check their viral loads. We make sure that they've got their medicine available in their cupboards. We make sure that they've got a long-acting reversible anticonception in their body so that they won't have more children coming up. And the one thing, and I've actually highlighted it, is what really made a difference for us, is that we were lucky that a local NGO from our town wanted to do a food parcel donation for us. So every child that goes home and discharged after being admitted for SAM for 3 months gets a monthly food parcel. And this NGO also visits them at home, and it's a really, really nice package, which really helps them a lot. I've also put here a Form 22. We've got lots of neglect, and then I really want to encourage you to make use of this form, even though it often doesn't really work, but then that's your contact with DSD and child welfare. Okay, so I've done a lot of talking. I think I went a bit faster than I thought. We still have about 15 minutes left. So I want to thank you all. There's so much to say about this. And I'm also really passionate about it. I just selected 3 things, but I also want to open the floor for questions that are not related to what I've said here. So I'm just going to stop slide sharing.
Thanks very much, Sybrich. That was amazing, so informative and practical. Thank you to those of there were some people who responded to your questions in the chat. So just to say, if you have any questions, you want to share any experience, or, any of the challenges or anything, please just raise your hand and we will just take it from there. In the meantime, just to remind everyone that this presentation is CPD accredited for those who've been online for 45 minutes. And if you can complete the poll at the end, and if you're not a RuDASA member, please sign up. We will put the link in the chat as well. So yeah, if there's any questions or comments, please feel free to go for it.
Yeah, thank you, Indira. I just want to also encourage people to share their stories, because we are sitting in this one regional institution here in KZN, but I know the things that we are seeing. And my question also to people out there is, what are we seeing? Are we seeing with edema, without edema? What is it that you're struggling with? Yeah, so please go ahead.
Yeah, I think this was a very relatable presentation. So I can't believe that of the 49 people attending, let's say 45, that there are no, experiences or even questions. Don't feel shy. You can just unmute yourself and ask the question. Oh, we have a question. Please go ahead. Is it Dihlolelo? I hope I've pronounced your name correctly. You can unmute. There we go.
Am I unmuted?
Yes.
Okay. Good evening, everyone. My name is Vivian. I'm in Limpopo. I wanted to check with the presenter, what is the receptive, how is the practitioners receptiveness about malnutrition below 6 months? Because we struggle with that.
I love this question, Vivian. Do you want to expand on what you're struggling with exactly?
It's more of the debate around MWAC for children below 6 can be, it's not expected, because before we used to think you can have a MWAC taken for children below 6. So now when you use the MWAC as one of the things to diagnose SAM in children below 6, it becomes the debate to say, can we really use MWAC while MWAC is not really, we don't expect fat and muscle stores in children from at around 6 weeks. So those are some of the things that we struggle with. So they want to remain with failure to thrive. And then when you're managing a failure to thrive and a SAM, it becomes different dynamics.
Yeah, I really understand where you're coming from. Look, if you're talking from there's different ways for me to answer that or to respond to that. First of all, I really see where this is coming from, because why would we say a 6-week-old suddenly your mucus is low, you can be a SAM? But the background of this guideline is that it's not academic guideline. It's not saying, okay, it's really to say we have to take this problem seriously and we have to recognize the kids. So I think what the makers of the guideline wanted to say is, okay, we know under 6 weeks, if you're 5 weeks and 5 days, are you not a SAM? And if you're 6 weeks and 2 days, you suddenly are. But it's just about really recognizing and taking the malnutrition seriously and recognizing it early. I think we can all say throughout South Africa, we have a problem in our non-breastfeeding moms that are feeding porridge very early, that they are trying to do formula feeding, but they don't have the money for it. So it's a huge problem group. And I think with this new guideline, they really want to focus on that group and want to say, okay, you know, let's take this child into consideration. And how they have done it is they just wanted to expand and use the same markers as they did above 6 months. You can argue until you know, how is a MUIC really reliable in a 7-week-old or in an 8-week-old? But I think just for easy use of the guideline, they said, okay, let's just start using MUIC. For me, the biggest problem is that now we have these beautiful MUIC tapes with all the color coding on it, but you can't use them below 6 months. So you really need to do a lot of education with the clinics and say, okay, let's just start doing it and let's just start recognizing it. And if there is a discrepancy, for example, what we often see is in our low birth weights and in our exprints that they'll do a MUIC at the age of 9 weeks and it's still like 10 or 10.5, but the baby's otherwise growing well. Are you then going to say he's a SAM? Well, I think you can just make that up for discussion with your referral institution or just say, okay, this is a case we're not really sure. Let's just monitor. Let's give a little bit more guidance, close follow up. So there's different ways to go about the new guideline. I don't think just saying, no, we're not going to do this. I think you can also just say, okay, let's just start doing it and let's just learn from what we're doing. And in our surroundings, suddenly you'll see, oh, wow, actually, we're picking them up so early with this MUIC. It might actually work. I'm not sure if you want to respond to that, Vivian.
No, I understand what you're saying, because we are trying as much as possible to highlight the importance of following the guidelines and using the guidelines with your own discretion. Some things you can see the clinical signs, the other things that are the nutrition information that you get in from the mother, how often do they feed, what do they feed, and all that.
Yeah.
So together they can give you a direction to say, definitely here there's poor feeding, and it
100%.
definitely going to lead you to managing that child as a malnourished child, and not just say
Yeah,
it's failure to thrive, because failure to thrive can be from many things.
yeah, I think as a pediatrician as well, we used to love that term, but it's making us also a bit uncomfortable. So maybe we can just say growth failure as a better terminology, because failure to thrive, or just say SAM with or without edema based on the MUIC or based on clinical, and with or without complications. I think that might make it easier. I see a question in the chat. Does clinical signs outweigh the diagnostic parameter? As we always say in all these guidelines, it's an equal. So it's not you need all of three. Let's say you are stunted, wasted, and low MUIC and clinical. If you just have one of them. So I think this is a really good question. And emphasizing this with our local clinics has really helped us, because historically they were only referring to us once the weight for height Z score was sort of below -3, or if there was a low MUIC. But now they're also referring to us, look, these children with malnutrition and that edema, so the SAM with edema, they often might actually have even a normal MUIC or like a weight for height Z score that is -2. But based on the edema, they are sending the babies to us. And it's really helpful because you can just say, based on clinical science, this child is a SAM, let's treat as a SAM. And then you can argue wherever you are if the child needs admission or not. In KZN, where we are in our district, we say admit.
Thank you. Thanks, Sybrich, for taking those questions. I saw someone else had their hand up. I think it was Nomkosi Mkwanazi. If you still want to ask your question, please go ahead. Or anyone else.
Yes, good evening. My question is regarding the prem babies, the very low birth weights, the low birth weights. At what age do they usually like catch up and we treat them like normal babies? usually, in terms of weight, in terms of growth and stuff?
Thank you, Nomkosi. That's also a really good question. The answer is not that simple. I'm not sure if you're all familiar, but we work with corrected gestational age. So then you can say, okay, this baby was born at 32 weeks. And if he is 8 weeks old, he now has reached his due date, sort of the corrected gestational age of being born, being term. So at the 8 weeks, you can't really say, this is now suddenly he's 8 weeks old, let's use a MUAC, he is a SAM. So you rather look at those growth per kilogram per day. That is not so simple for clinics to use, and we realize that. But I think it's also a bit of common sense that if a child has been in hospital for a long time and you're now receiving him at the clinic or at your district hospital, he's being down referred, from that moment on, the only thing that you want to see is growth. If there's anything, if the baby is not growing or losing weight, that is a problem. And then the growth that you see, you want to see adequate growth. And I'm happy to share that one more time. Let me see if I can find it. Because it's actually quite nice, the growth per kilograms per day. So how long does it take for a child to catch up? It's difficult. If a child was born at 1.5 kilos, by the time he is, and he's a prim, by the time he's term, he wants him to be sort of at 2.5. So it's just a lot of common sense in how you go about, here it is, sorry, in how you go about assessing the growth. Apologies, I didn't take it to that screen. Sorry. Yeah, so it basically speaks to, you keep on correcting for gestational age until they are a year old, and some say even 2 years old. So the catch-up growth takes months, as long as you just see growth. So let's say, okay, it was prim. By the time he's term, you want him to be around 2 kilos or 2.5, depending on where they're coming from, because obviously a baby that was born with 900 grams is now going to take a lot longer. The problem lies is that we've got a lot of term babies that are low birth weights, and those are IUGR babies, so intrauterine growth retardation. And those are actually your ones to watch, because they might have growth problems. Why is he even IUGR in the first place? And actually, we should be monitoring these babies until they're at least 3.5 kilos, and then say, okay, I'm happy you've been growing. Now you can, follow your normal program. But yeah, our clinics and our hospitals are not really geared up for this. Sorry, a bit of a long answer to that question. Does that help you? So I don't give you like a package. It really depends on the individual child.
Yes, you did answer my question. Thank you.
Okay.
Thanks. Are there any more questions? We're almost at the end, but we do have time for questions and discussions. So please feel free to chime in.
I actually have a question to the audience. I'm not sure if people want to share, but do people recognize the number of SAMs that you see in a year for our regional institution? Do people see more or less, or?
What do you mean more or less compared to?
Yeah, I mean, do people see a lot of SAM in their institution? Is it still a problem out there?
I would say yes. I would say
Yes,
yes.
still.
Yes,
Sorry,
we still
Vivian.
have.
Sorry,
We
I
still
see
have.
Tembela Mtembu has raised their hand. Please go ahead.
Good evening. I hope I'm unmuted.
Yes.
Yes.
Thank you so much for the beautiful topic. From where I am, it's the big rules of KZN, and I think we're seeing quite a lot number of SAMs. Currently, we have 2 SAMs in the ward. One is very much complicated, and our problem is the late referrals, especially with SAMs with edema, because of the plotting. So they'll plot as a ma'am or a NAM, and then they get being referred late, and they're being referred for the complications rather than the same. And the other problem we're seeing, it's the poor nutrition at home. So they try by all means to save the milk, especially the ones that are on formula. So they maybe put more milk than the scopes and the porridge mixing with the milk, which gives us more complications, I think. And also we have a high number of patients that are using traditional medicine or believes in traditional medicine, which makes it more difficult for us to even see the children that are same at the beginning, where they come later on because they've been undergoing the traditional routes than seeking medical attention.
Yeah, thank you for the beautiful words that you've spoke. I think is so true. And that inflammation that I talked about is really at the core of it, because what people don't understand is that if you start giving porridge or mini meal or whatever to a baby, the gut is just going to be sick. It is inflamed. It is shedding the foamy. It's just a sick gut, and you get into this enteropathy that is just ongoing, and the diarrhea doesn't stop. I'm not sure if you see it as well, but we've got like diarrhea lasting for 2 weeks, and only when we put them to like milk-free feeds, lactose-free feeds, it resolves. I mean, it's a lot of time, and the herbal medicines is also a big problem. The first thing that you mentioned about clinics recognizing SAM with edema, and that's what I said just now as well, that is so important. It basically, if you go out into the communities, you'll see all the nice chubby cheeks. And if they put a hat on, you don't see the sparse hair. You think they're actually quite all right. If I would show my non-medical friends, they wouldn't recognize it. But seeing that we are all healthcare workers, I think we need to go out there again to our clinics, our community healthcare workers, our nutritional advisors, and just show them the pictures. This is a SAM. And then suddenly they will say, oh, we recognize this. And we actually have this. Suddenly you're like getting them left, right, and center, because now the clinics are starting to recognize it and just referring children with edema. So yeah, we have seen an effect of just doing training there.
Thanks for the question. So Hannah Edgecombe, your hand is up. Please go ahead.
Hi, thank you so much for a great presentation, Dr. Tiemersma. Mine is less of a question and actually more of a comment related to what people are saying about how we all see sort of a higher incidence or maybe more severity of SAMs in babies where they're being formula fed. Quite recently, I've noticed a couple of issues where moms were breastfeeding and something has been said at the clinic that's put them off. Whether that is she is HIV and unsuppressed, and someone has said something about formula will be safer because your baby's going to get HIV from you, or in a recent case where it was a teen mom of twins, one of the twins wasn't growing well, and someone at the clinic said to her, you need to use formula because your baby's not growing. And what I imagine was intended from them to be you should augment your feeding with formula or top up was very much interpreted by her as breastfeeding is bad for your babies. And now we have two twins to a mom who's 15 years old with very little social support who are now both formula feeding. And you just look a couple months down the line and you see these kids coming back as severe SAMs. So I think it's just really important for all of us to really engage our clinics, because we know that we're all trying to do the right thing and it's all coming from a good place, but that we just have to be so careful with what we say to mums, particularly with regards to anything that may discourage them from breastfeeding, because that's one of our sort of greatest weapons in preventing and dealing with these SAM babies. Thank you.
Yeah, thanks, Hannah, for that comment. I think it's really worthwhile. This is not the presentation about the new V2P guidelines, but it's now actually allowed to mix feed. And we have been grabbing sort of a small subscript in one of the tables that's speaking about breastfeeding. That's you are now, if the situation is not others, you can just mix feed. We are just saying, please, please, rather just mix feed. If a mom is a teenager, needs to go to school, breastfeed your baby in the morning, express. But if there's not enough, just top it up, at least as there's some breast milk going in. So I'm not sure if I'm making some wrong comments everywhere in South Africa, but please rather do mixed feeding than no breastfeeding at all. There's also another question about a specific Muick tape. I have been asking this in province if we're going to get this available, a Muick tape for less than 6 months. You rather maybe have one Muick tape that has got sort of the two, or that you can just round for the one and the other. But it might make things also really complicated. So far, we actually, unfortunately, don't have a collar tape as yet, as far as I know. So I'm hoping with a new national release that they're also going to release these new Muick tapes. And maybe we can also ask NGOs like Grow Great if they can help us with this. Yeah.
Okay, thank you. We have reached, well, we've gone a few minutes over our time, but thank you so much for your engagement and for staying till the end. And thank you so much, Dr. Tiemersma, for this amazing presentation and also for your engagement. We really appreciate it, especially, as I said, this is Youth Month. So this presentation, we will get your permission to post it on our YouTube channel. And if there's any comments, you can, leave it on the video. And if you have any other questions, you can, if you're in a RuDASA group, please post your questions there. We'll get it to Dr. Tiemersma. Or also, if you want any of the resources that she shared in a presentation, please let us know, and we'll make that available. So yeah, that's the end, and thank you very much. We will say good night.
And please don't hesitate to email me if you want to know more or you want to cooperate with research or anything else. Thank you.
Oh, yes, sorry, there's one other thing. There's a poll that I'm supposed to share, and I'm just looking for the one on, I don't see our poll here for okay, no, for June. All right. I'm not sure if Steph is able. Oh, you've raised your hand, Steph, so go ahead.
Okay, I was just going to say put the poll on.
Yeah, I don't see the poll. I see lots of others, but
okay,
not
so
the
what we can do is there is another poll. Just if you just give me a moment to get the link,
okay.
because I can't see the poll. I'm not on as a host.
Yeah, no, I don't
Yeah.
see
So just give
one.
me a minute. We have an alternative one that we can use if this happens.
Okay, sure. Unless it's this one. Oh, yes, I see there's a webinar polls. Okay, we'll put that. So if for anyone who's still here, please, if you can, just answer these questions just to rate our presentation. Thank you.